All right, this is part two of two. In the previous presentation, we talked about the quote-unquote discovery of hemoglobin cycling. We talked about the use of system dynamics modeling to develop a model to find an ESA dosing regimen to stabilize patient hemoglobin levels in a target range. And we ended with how we used the model to simulate how the current protocol works. All of that is described in part one. If you missed that, you may want to go take a look at that, but I will move on from there now. And so let's talk about what actually happened. You recall in the first part we talked about patient number one, who we presented data for patient number one up to this black line for about 674 days, something like that. And we were noting the many excursions the patient made above and below the target range and the wild dosing pattern that was followed attempting to get the patient's hemoglobin under control. Under the model-based protocol, for days 675 to 1200, 525 days or something like that, we found that we could give a stable dose, a single dose, and do a very good job, remarkably better job, of keeping the patient's hemoglobin level in the target range. So with this patient we had a lot of success. These variations now were due to other factors that the practitioner could get a better handle on managing and dealing with situations once the appropriate dosing regimen for the ESA was known. We also talked about patient two, and we saw the same kind of highly variable ESA dosing and the associated highly variable hemoglobin. Here we have the patient's hemoglobin staying in the target range most of the time, and a feature of the target range is that it was narrowed. This date happens to be May of 2010, but the range was narrowed from 10 to 13 grams per deciliter to 10 to 12 grams per deciliter. And in the initial phase we again found a stable dose, and we did some experimentation, perhaps maybe even built a second model for this patient, found another dose, began to see the patient's hemoglobin coming down appropriately. But then when we wanted to achieve a stable hemoglobin within the target range, developed a third model. And this TP pattern you see here is just a result of the titrating available vial sizes of the dose. We give two small and one large, two small and one large. That, for example, that would achieve a dosing level probably a little bit closer to the lower level than the higher level. And we did a very good job of keeping the patient there as well. For day 722 to day 645, that's quite an extensive period of time which we're able to do that for that patient. Now, as has been reported at the American Society of Nephrology in a conference in the fourth quarter of 2010, Mayo Clinic reported the results they were able to achieve using this methodology. And in the process of doing that, they defined who they are, an academic nonprofit institution. The dialysis services are the service arm of the Department of Nephrology and Hypertension. 17 dialysis care facilities in 3 states, about 625 to 650 prevalent patients, 15 physicians, 7 allied staff. They've got common policies and procedures that they use in the shared dialysis database. All right. Time-wise, we don't have time to describe how this project morphed from the initial requirement to develop a reporting system. And we were hired to, my company, Advanced Management Group, was hired to do a reporting project in the first quarter of 2007. But it wasn't until the first quarter of 2008, in looking at some of the results of the reporting and data cleansing we had done, that we saw these meaningful dynamic patterns mentioned in session 1. Having noticed those patterns by the second quarter of 2008, we had a model built and 2 pilot studies completed by the fourth quarter of 2008. Organizational rollout was complete by third quarter of 2009, and we hit a significant milestone in the second quarter of 2010 with 90% of patients stabilized in the target range of 10 to 13. And then after the target range was narrowed, a second milestone we hit, 75% of patients stabilized in narrower target range of 10 to 12. And those numbers continue to sustainably and continuously improve. I put this chart in the presentation as an artifact of the project. You remember one of the main messages I mentioned at the beginning of part 1 is that system dynamics was used to redefine the problem. Well, this is a very busy chart, but what it really is a behavior over time chart of 3, 6, 8 variables. The ESA doses, both the recommended in the squares and the actual hemoglobin values here in this chart in blue, and a number of other curves. I won't take time to describe what they are. But the message in this is what we're able to do is to lay this chart on top of a database of all 650 patients. And we have the practitioners now reading behavior over time charts to see the story and the data from a dynamic perspective. That is a redefinition of the problem. And as has been shown in this project, the benefits of that perspective are far outweighing the more static contemporaneous look at data values for hemoglobin, for example. There's a story in here that the providers are learning to read and understand and deal with. So I just put that in as an artifact of the chart. It was a very useful application, and we developed a web-based application to show behavior over time of critical variables. Improved healthcare value delivery. Value, quality over cost. Improved quality at a reduced cost. First, I want to talk about improvements in patient quality of life. Then we'll talk about staff productivity, and then very surprising dramatic cost reductions in the use of the drug. This chart shows the percentage of patients in the target range month by month. And as you can see, we've made steady improvements of up to 90% of patients in the target range. For the vast majority of these patients, they're in the target range and staying in the target range, which is that's spelling health for the body, with a constant level of oxygen supply to all the vital organs of the body, as opposed to a highly variable oxygen supply. This is very good for them, and it's got anemia under control, and many of the patients are benefiting from that. I wish I had time to tell some of the stories about how patients are recovering and feeling better. I'll just summarize one by talking about the woman who, instead of going home sick after dialysis, was going to go shopping with her daughter right after her dialysis session. This was for a patient that we got stabilized. That was really gratifying to hear. I'd mentioned that the range narrowed. Here we show the percentage of patients who are in the narrower target range. Both of these measures are improving, steadily improving, and sustainable, steady progress towards high performance. This is a snapshot of January 7, when we walked in the door, to May 11, the distribution of hemoglobin values from 9 to 14. And the only thing I want you to observe is in January we had this very high percentage of patients above the target range, and not a very good distribution of hemoglobin levels at all. Here in May of 2011 we're moving towards a much more centrally, a better distribution of hemoglobin values. Very few out here. We've got more than we would like down low again. Now, with respect to the narrower target range, we have some work to do, but we do have the tools in place to do that. and we're making progress towards getting this distribution tightly within the target range. This has been a great improvement. One of the amazing things that happened was before we began this project, the average ESA cost per patient per month was about $650. As we began enrolling more and more patients and ramping up quickly during 2009, we now have a cost of down to $400. And if you do the arithmetic, you'll see that's a savings of over $1 million per year from this thing by the better use of erythropoietic stimulating agents. Okay, that has been super. Now, we're not going to make the claim here that our study and our project reduced hospitalizations, but we did make the observation that the number of discharges per patient year decreased by 27%, and the number of days hospitalized per patient year before implementation and after implementation decreased by 30%. There were no other systemic process improvements or performance improvement projects going on. We're not aware of any other special causes that may have given these huge changes. As I say, we're currently studying this, and we'll be documenting more of this in the future. But this is an enormous drop in hospitalization rates. That spells a lot for patients. And on the financial side, that is a savings of multiple millions of dollars per year, as most of these patients are Medicare patients. I had the privilege of sitting in on a couple of Grand Rounds presentations, and these are quotes from the nephrologists and hematologists. This approach applies to all of medicine. This approach could revolutionize medical care. It's an approach that system dynamics, that is, asks exactly the right questions that are not being asked in medical schools, and effectively addresses fundamental issues. And one of my favorites is, if we followed this, we would be placed in grave danger of actually learning something. So there's a tremendous amount of excitement about this, and we have a number of future applications and development in mind. First, we want to make an extension to the erythropoietic model by including factors it currently doesn't include, such as iron metabolism, for example. And then, in a completely unrelated area, but related in its concept, is the use of methadone for pain management. Similar to the erythropoietic model, the analgesic effect of methadone is delayed by about 4 days, and that spells all sorts of havoc, devastating havoc for patients. Last year, over 7,000 people died from methadone poisoning, and much of that could be due to that misunderstanding of the delays in the system. We want to take a look at antibiotics, immunosuppressants used for organ transplantation, doing the right level, anticoagulants. And then all across the country and throughout the world, there are departments of systems biology emerging that are going on. Finally, we have formulated a biophysical system dynamics group, and if you, again, go back to the title page and look at the link there, you'll be able to navigate your way on the System Dynamics website to the description of that special interest group, looking at the applications of system dynamics to biophysical system dynamics. 3 messages. Anemia is a big deal for dialysis patients. System dynamics help redefine and solve this problem, and system dynamics modeling could be the toolkit we need to develop the emerging world of individualized or personalized medicine. Thank you so much for listening.